Good morning, ladies and gentlemen, dear professors and dear doctors. My name is Bojana Jedoksic, a board member of Thyroid Federation International. On behalf of our organization, I welcome you to the Graves' Disease Awareness webinar. As you know, Graves' Disease Awareness Month in July aims to increase understanding and support for those affected by Graves' disease. By spreading the knowledge, Thyroid Federation International fosters a supportive community, encourages early diagnosis, and highlights the importance of an appropriate care for those living with Graves' disease. Ladies and gentlemen, let me introduce and announce our guest speaker, Professor David S. Cooper, Professor of Medicine and Radiology at the Johns Hopkins University School of Medicine. Professor Cooper is internationally known in the thyroid and endocrine community for his work treating Graves' disease and subclinical thyroid disease and various aspects of the diagnosis and management of thyroid cancer. He was the chair of the American Thyroid Association Guideline Committee on Thyroid Nodules and Thyroid Cancer in 2009, which has become one of the most highly cited recent publications in endocrinology. Professor Cooper is one of the rare physicians who has successfully crossed back and forth between his patients' care responsibilities and his commitment to medical education in endocrinology. Ladies and gentlemen, Professor Cooper.
Hello, my name is Dr. David Cooper. I'm an endocrinologist at Johns Hopkins University School of Medicine in Baltimore, Maryland, United States. And I'm going to be talking to you about Graves' disease. I don't have any conflicts. I want to dedicate this lecture to my friend and mentor, Dr. Larry Wood, who many of you may have heard of or know. He was a good friend to me and got me interested in patient education. He was the founder of the Thyroid Foundation of America, and he also was the first president of the TFI. So this is an outline of my presentation. We're going to talk briefly about the thyroid and where it is, and we'll talk a little bit about what it does. And then we'll focus mostly on Graves' disease, how we diagnose and treat it. And at the end, we'll talk about thyroid eye disease. Just a quick note, eponyms are diseases that are named after the people that first described them, like Hashimoto's or Cushing's, Graves. And there's two different ways of writing these, either with a possessive, like Hashimoto's with an S and apostrophe, or just Hashimoto. It used to be that this was more popular, but now in writing, people are preferring not to use the possessive, like Cushing or Dupuytren. But what's never right is to say Graves' disease with an apostrophe S, because, of course, his last name was Graves with an S on the end. So either one of these is correct. This is not correct. But many people still do this, especially even doctors are doing this incorrectly. So this is a drawing from actually a book called Your Thyroid that Dr. Wood and I and Dr. Ridgway wrote for patients. And this is a drawing from that book showing the location of the thyroid gland in the front of the neck wrapped around the windpipe. It's right in the front under the skin. It's very easy to feel on physical examination. This is a normal thyroid that's been removed from a person. And this is the dimensions of the normal thyroid. So each lobe, each side of the thyroid has a dimension of about 4 by 2 centimeters and about 1 centimeter thick. So each lobe is about the size of a teaspoon. And this is the normal control of the thyroid. Like all the glands in the body, the thyroid is controlled by the pituitary gland and a higher up structure called the hypothalamus. The pituitary secretes thyroid stimulating hormone, or TSH, and that's what tells the thyroid to make the thyroid hormones, T4 and T3, or thyroxine and triiodothyronine. And then there's a feedback system. So then the pituitary decreases its output of TSH in response to that. So this is a feedback loop. And this is the way all the glands in the body work. Now, the thyroid actually makes two hormones, T4 and T3, and T3 is actually more important than T4 metabolically. And thyroid hormone, especially T3, is required for all the cells in the body to function. It influences how the cells differentiate from growth and metabolism. And it's considered to be the major metabolic hormone because they target virtually every tissue in the body. And these are just some of the things that thyroid hormones do, especially during in utero development. It's important for brain and overall growth of the fetus. In childhood, it's important for growth and development. And then in adults, virtually every facet of how your body is functioning in terms of cardiac function, liver function, metabolism, your brain, it's all dependent on thyroid hormone. Now, thyrotoxicosis is just a medical term for too much thyroid hormone. Another word is hyperthyroidism. There are some semantic differences between these two words, but I'll just use them interchangeably. And this is a situation where there's just too much thyroid hormone in the body. There are many things that can cause it, including taking too much thyroid hormone, for example. But Graves' disease is by far and away the most common disease causing hyperthyroidism. It's pretty common, 1 to 2 per 1,000 people. So I was just thinking like the city of Paris with 2 million people, between 2 and 4,000 people every year develop Graves' disease in Paris. About 1 in 50 women will develop Graves' disease in her lifetime, because it's much more common in women than it is in men, as is true for most thyroid diseases. Now, these are just symptoms of thyrotoxicosis or hyperthyroidism. I'm sure these are familiar to most of you. Nervousness, hyperactivity, but also fatigue if people don't sleep well at night, heat intolerance, sweating, increased appetite, and despite that, often weight loss. In women, menstrual disturbances, tremulousness, and weakness. And then these are some of the things that a doctor or nurse might find on physical exam. A goiter, which just means an enlarged thyroid, retraction of the upper eyelids and prominence of the eyes, warm, moist skin, a tremor or shaking of the hands, rapid heartbeat, sometimes rhythm disturbances of the heart like atrial fibrillation, and very, very active reflexes. This is just a typical woman with Graves' disease. You can see her eyes are somewhat prominent. There's some swelling around her eyes, and also you can see that her thyroid is enlarged. As I mentioned, this is very common. It occurs in about 2% of all women. There is a genetic relationship, so thyroid diseases are more common in family members, but even in monozygotic twins, that's identical twins, not every twin has Graves' disease like the other twin. Only about 50% are concordant. So there are probably other factors besides genetics, like the environment, that are important. As we mentioned, or I mentioned, women much more than men, 5 to 10 to 1 ratio. And as you probably know, this is an autoimmune disease. That is, where the immune system is receiving the body, in this case, the thyroid, as a foreign invader and attacking it. And there are antibodies that are developed against the TSH receptor, which I'll go into in a second. And this stimulates the growth and function of the thyroid. Now, what triggers the development of Graves' disease is really not known. It's been known for more than 100 years that stressful situations might be a trigger, death in the family, a divorce, that sort of thing. And also infections may trigger it. And in fact, there's some data to show that COVID infection may have triggered the development of Graves' disease in certain people during the COVID pandemic. So this is that figure that I showed you a minute ago, showing TSH from the pituitary stimulating the thyroid to make thyroid hormone. And now here we have the thyroid, and it's being stimulated by thyroid stimulating antibodies. This is the autoimmune response, stimulating the thyroid, and then the thyroid responds to this by growing and making more thyroid hormone than is normal. That affects the anterior pituitary gland, and TSH levels are suppressed from the negative feedback. So this is what we see in a patient with hyperthyroidism. Thyroid's enlarged, making excessive amounts of thyroid hormone and a low TSH level. These are just some of the findings on physical exam that I showed you in a little minute ago in that drawing. So enlarged thyroid, eye disease, there's something called thyroid dermopathy or preepidermic edema, where there's thickening of the skin on the front of the legs. This is quite rare. Also, another phenomenon called clubbing of the digits. This is also very, very rare. These are just some autoimmune things, findings that we see in patients, not specific to the thyroid specifically, but from any autoimmune disease, vitiligo or loss of pigment in the skin, prematurely gray hair, and then this odd phenomenon called dermatographia, where by scratching the skin, it causes inflammation and swelling. And you can see here this person wrote hello everyone on their skin by scratching their skin. So in terms of diagnosing thyrotoxicosis or Graves' disease, we want to measure the TSH, which is always going to be low. The T4 and T3 are going to be high. And the T3 being high and T4 being normal is seen in about 5% of patients. So that's called T3 thyrotoxicosis. And of course, these antibodies that are stimulating the thyroid, they're called anti-TSH receptor antibodies. They're going to be present in the blood and we can measure them. And then importantly, antibodies that are seen in many autoimmune diseases, thyroid globulin antibodies and antithyroid peroxidase or TPO antibodies, these are often positive in Graves' disease, but they really don't have any meaning in terms of what's going on. They're positive in Hashimoto's thyroiditis and Graves' disease, but it doesn't mean the person with Graves' disease has Hashimoto's thyroiditis or this other phenomenon that's been called Hashitoxicosis. That's not what that means. There's no reason to check these antibodies in patients with Graves' disease. So the anti-TSH receptor antibodies, or TRAB, TSH receptor antibody, this is the general term, but there are other initials like TBII, which is TSH receptor inhibitory immunoglobulin. This is just refers to how it's measured in a test tube. And then there are other antibodies measured called thyroid stimulating immunoglobulin, or TSI, or TSAB, thyroid stimulating antibody. This is another term to refer to a way of measuring these antibodies in the test tube. So in a patient that's suspected of having Graves' disease, you want to measure the T4 and T3, which would be elevated. The TSH would be low. And then we would measure the TRAB or TSI. These are the anti-TSH receptor antibodies. And if they're elevated, this person has Graves' disease. And if they're not elevated, they do not have Graves' disease. These tests are extremely sensitive. And Graves' disease patients have positive antibodies in at least 98% of the time. There are very, very rare patients with mild Graves' disease where the antibodies may not be positive, but this is very, very rare. There are some other ways of looking at the thyroid, which probably are not necessary when we have the blood tests that are positive in the previous slide that I showed you. And, we can use radioactive iodine to take a picture of the thyroid because the thyroid uses iodine to make thyroid hormone. I've shown you over here on the left a normal scan where there's iodine was given to a normal person. Then a picture was taken of the thyroid, and then Graves' disease. You can see the thyroid's enlarged and more active and taking up more iodine. But this test is really not necessary to be done if the antibodies are positive. And another quick way of looking at the thyroid and making a diagnosis is by ultrasound, where here is a normal thyroid with the normal blood flow in the thyroid, which is quite low. And then here's a person with Graves' disease showing very, very, very increased blood flow, which is typical and an easy way of looking to see whether the person has Graves' disease just by doing an ultrasound, which can be done in the doctor's office. These are the treatments of Graves' disease. There are 3 of them that are currently available, and these treatments have been used for almost 80 years. There's nothing new right now, which I'll talk about in a minute or at the end of the talk, but right now, these are the treatments that we have. Antithyroid drugs, which decrease the thyroid's ability to make thyroid hormone, radioactive iodine, which destroys the thyroid by giving the thyroid radiation, and surgery, which of course removes the thyroid. These all have advantages and disadvantages, and we'll go through each one of these in detail in the next few slides. So why would a person favor antithyroid drugs over radioiodine surgery. And patients with milder disease and small thyroids and thyroid hormone levels that are not so bad have a chance of having what's called a remission, where after a year or two or 5 or 10 antithyroid drug therapy, and the drug is stopped, the disease goes away and the person does not have recurrent hyperthyroidism. Elderly people who are at higher risk for surgery would be a candidate. And then people who have eye disease, as I'll mention in a minute, they are not good candidates for radioactive iodine. So this includes many, many people. And the antithyroid drugs are probably much more likely to be prescribed than the other two modes of treatment. On the other hand, radioactive iodine may be something that somebody would want in the absence of eye disease. Also, women who are planning a pregnancy in the future who do not want to be put on antithyroid drugs because these can cross the placenta and potentially cause birth defects. Radioiodine is something that they might want. And then in elderly people who don't want to be bothered with taking antithyroid drugs, and surgery would not be an option for an older person, radioiodine would be a good choice. And then there are people who have surgery. Some people have very large thyroids, which is bothering them in terms of excessive pressure in their neck. When there's coexisting thyroid malignancy or suspicious of malignancy, there's another condition called hyperparathyroidism due to enlargement of the parathyroids, which are behind the thyroid, causing a high blood calcium level. So if the person's having surgery anyway, they might as well just have their thyroid removed. Women planning a pregnancy, as I mentioned before, we do not necessarily want to use antithyroid drugs in those women. And then people who have eye disease who can't tolerate the drugs, surgery would be a good option. Now, this is just a slide looking at the trend of the different treatments for Graves' disease over time in the United States, but this is true for all over the world too. And as you can see that radioiodine, shown in red, has been going down in terms of a popular treatment, and antithyroid drugs in blue now account for the vast majority of treatment for patients with Graves' disease in the US. And this is true, as I said, for the rest of the world as well. And in a recent survey of almost 1,500 endocrinologists from all over the world, they were given a typical case of Graves' disease and asked what would be their treatment of choice to start out with. And you can see that over 90% of doctors in the world, and this didn't matter where in the world they were, favored antithyroid drugs as the initial treatment. And why was that? And they were asked why. The first number one choice was the hope of a remission. That is, the disease would go away. And second choice was avoiding hypothyroidism. So if you have radioactive iodine and surgery, the patient inevitably will be hypothyroid and then dependent on thyroid hormone replacement therapy for the rest of their life. So this is methimazole. This is one of the antithyroid drugs. And carbimazole is a drug that's used in the UK and other former British Commonwealth countries, and it's converted to methimazole in the blood. These are the two drugs that are used now in most of the world to treat Graves' disease. This is Dr. Edwin Astwood, who developed these antithyroid drugs back in the 1940s, 50s, and 60s. And these are very, very powerful drugs that block the utilization of iodine by the thyroid. And in turn, that lowers the thyroid's ability to make thyroid hormone. So the thyroid hormones are made out of iodine. The thyroid takes up iodine and turns it into thyroid hormone. And these drugs block the thyroid's ability to do that effectively. On the other hand, there are also possible effects on the immune system of these drugs, because when people take the drugs, the levels of the anti-TSH receptor antibodies go down. So there are lots of questions when a patient first sees us in terms of what to do with the medications. The dose of medicine is based on how bad the hyperthyroidism is. And we always want to use the least amount possible because the side effects are related to the dose of the drug. Patients should be told about the possible toxic effects of these drugs or side effects in writing, if possible. How long should the patient be treated? Um, what's gaining popularity now is not just treating for a year or two, but possibly even 5 or 10 years, since there's some evidence that the longer a person is treated, the more likely it is that they will remain in remission when the drug is stopped. And most patients are good candidates for antithyroid drug therapy. These are some of the side effects of the antithyroid drugs. So the most common is itching, rash on the skin, but GI distress also. Maybe 1 to 5% of people get that. Agranulocytosis, or lowering of the white blood cells, is a very severe allergic reaction, and possibly 1 in 500 people will have that reaction. This reaction is dose related. That is, it's more common with the higher doses of drug. This usually occurs within the first few months of taking it. Liver damage also can occur rarely, also usually in the first 90 days, and may be related to the dose as well. There are other rare side effects that I won't go into. So the term euthyroid means normal thyroid. Normal thyroid hormone levels don't occur immediately. It takes weeks or even months of methimazole treatment for the levels to normalize. And the time it takes depends on how bad things are to start with, how big the thyroid is, because there's a lot of thyroid hormones stored up within the thyroid. These drugs only block the synthesis of new thyroid hormone. They don't do anything about the thyroid hormone that's already in the thyroid, which is then going to be released. And then the dose of methimazole is also important. The higher the dose, the quicker the resolution of the hyperthyroidism. But again, the side effects are related to the dose, so we don't want to give any more than is necessary. And as I had mentioned previously, the levels of anti-TSH receptor antibodies, shown here in red, go down when a person takes antithyroid drugs. They also go down after surgery, and you can see they actually go up after radioactive iodine. But the question is, why do they go down with the antithyroid drugs? And there may be effects on the immune system of the drugs that ultimately cause people to go into remission after a course of treatment of years. Now, just because they go down doesn't mean they become normal, these levels, the levels of anti-TSH receptor antibodies. So you can see in this cartoon, the levels went down, but never got to the level of normal, which is shown by the dashed line here at 10, this line. So in people whose levels went down, but never became normal, most people relapsed if the drug was stopped. But in those people who attained levels that were essentially normal, far fewer people relapsed when the drug was stopped. So it's not just a decline in the treatment, in the antibody level, but it's normalization of the antibody level that's important. And here we have one study. There are others also just looking at the rate of relapse when the drug is stopped according to how long the person took the drug. And you can see here that in people who took the drug for a year or 2 or 3, the relapse rate when the drug was stopped was in the 30 to 40%. But in people that took the drug for more than 6 years, the relapse rate was in the 15 to 20%. And this is why we now believe that it makes sense in people that are taking these drugs without any difficulty to continue the drug for a number of years, because we're hoping that when they finally stop, they will be in a long-term remission. So this is just an algorithm for the current management with drugs and radioiodine and surgery. So the person is diagnosed, they're treated with methimazole or MMI, and then we measure the antibodies. And if the antibodies are still present, then you can't stop the drug because the person will just go back and be hyperthyroid again. So at that point, you could say the person might want to opt for radioiodine and surgery, but the person could also opt just to take methimazole again for another year or 2 or 3. If you stop the drug and there's a relapse, then the same thing would come up, which treatment would they favor. And now what I'm saying is that another strategy is just to measure the antibodies, and if they're still present, just keep the person on methimazole. Or if you stop the drug and the person relapses, again, put the person back on methimazole for a relatively long period of time. And I think this is what many, many people are doing now and is favored by most patients. Let's just talk quickly about radioactive iodine. Radioactive iodine comes in a capsule that the person swallows. It's not a liquid. And inevitably, people become hypothyroid after radioactive iodine. It's not a side effect. And in fact, for most thyroidologists, the goal is to make the person hypothyroid, because that will then cure them of their hypothyroidism. But of course, then they will be on levothyroxine therapy forever. Radioiodine takes many months to work, and it does not work in everybody with one dose. So about 20% of people need to be retreated. Some people become transiently hypothyroid after radioiodine, and then that can relapse, or sorry, that can fade away, and the person can become hyperthyroid again. And also, it's important in older people that some of them have worsening of their hyperthyroidism, which potentially could be dangerous in an elderly person. There are lots of concerns about radioactive iodine. It does not cause infertility or birth defects in people that have received it in the past, but it obviously would be absolutely contraindicated in anybody that's pregnant. So every woman who is going to be treated with radioiodine has to have a pregnancy test. There may be some evidence that thyroid cancer may be more frequent in people that take radioiodine for a large multinodular goiter, but not for Graves' disease. And there may be some evidence of increases in breast and small bowel and stomach cancer. And for this reason, this is one of the main reasons that people are turned off by the idea of radioactive iodine. And then also it may worsen pre-existing eye disease and induce eye disease in people that don't have eye disease. And this, again, is a real worry for patients and one of the main reasons why radioiodine has fallen out of favor. And as I said, it can worsen thyroid function after radioactive iodine. So let's just talk about the eye issue with radioactive iodine. I'll talk about that in a minute. But so these are some of the pros and cons of radioactive iodine. It is definitive, it is effective. It doesn't really have any major side effects. It's relatively inexpensive. It's easy to do, and the thyroid shrinks. But it doesn't work right away. People become hypothyroid and they require lifelong replacement therapy. It may worsen eye disease. There is this concern about cancer and weight gain. Hair loss is a fear that really doesn't play out, but people are afraid of this. And also, when people are treated with radioactive iodine, there are safety precautions, that is, in terms of staying away from family members, avoiding sharing food or drink with other people, that also put people off. As far as surgery is concerned, you can't have surgery safely unless thyroid function is normal. So the typical way of preparing patients is to normalize the thyroid function with methimazole and add iodine. It's called potassium iodide, or SSKI, about a week before the surgery. This decreases losses of blood in the surgery. There are other ways of preparing people without methimazole, but then the person ends up having surgery when they're still hypothyroid. There are complications of surgery, and of course you might expect that the lower rates of complications would be with those surgeons who have more experience. So it's important for people to find a very experienced thyroid surgeon. The main side effects or complications of surgery are hypoparathyroidism due to damage of the parathyroid glands during the surgery, damage to the nerve that controls your voice. So hoarseness would be the effect of that. And at least in the United States, most thyroid surgeries are done by what are called low volume surgeons, that is, surgeons who do not specialize in thyroid surgery. The indications for surgery would be a woman who's planning pregnancy in the future, who does not want to be on antithyroid drugs, people who can't take their antithyroid drugs as faithfully as they should, people with a very large thyroid. Radioactive iodine doesn't really work that well in people who have very large thyroids, people who have suspicious nodules or cancer, and then coexisting hyperparathyroidism, where the patient's going to have surgery anyway. And this is just a slide looking at the complications of surgery. So the curve going down like this means the lowest level of complications. And here, this is the number of thyroid surgeries done by the surgeon per year. And you can see that a person needs to do at least 20 or 30 thyroidectomies a year to have the lowest rate of complication. So these are just the treatments that we have discussed: antithyroid drugs, radioiodine, and surgery. There aren't a lot of studies that have compared the three in terms of how patients feel or how they do many years later. This is just one of them, though. This is about 1,200 patients treated with Graves' disease 6 to 10 years earlier, according to practice. And some got radioiodine, some got antithyroid drugs, some got surgery. And then quality of life scores were compared to the general population. This is a Swedish study, so we're looking at the general Swedish population, which is shown in red. And these are just the domains in these in this quality of life score: functional, emotional susceptibility, depression, anxiety, tiredness, eye symptoms, hypothyroid, etc. And the red is the general Swedish population. And these other lines are people who had Graves' disease treated with antithyroid drugs, radioiodine, and surgery. And regardless of the treatment method, people with a history of Graves' disease had worse thyroid-related quality of life scores many years later compared to the Swedish population. But it turned out that people who received radioactive iodine as their treatment, that's the black line, had worse quality of life scores compared to people who were treated with surgery or methimazole. And for this reason, and again, there are other studies, this is another reason why people are now favoring long-term antithyroid drug therapy as the main treatment of Graves' disease. There are other potential drugs coming along in the pipeline. There are drugs that may block the TSH receptor so that the antibody can't bind to it. There are drugs that can bind to the TSH receptor and block the antibody's ability to increase thyroid hormone growth and synthesis of thyroid hormone. And then there are drugs that are being used to suppress the immune system. And I predict that in the future, these are the kinds of drugs that will be used to treat Graves' disease rather than methimazole. This is just a slide from Dr. Aswood in one of his articles back in the 1940s. And he said, when means are found to prevent the occurrence of toxic reactions from antithyroid drugs, or when a compound is discovered which does not give rise to side effects, then it will be possible to treat all cases of hyperthyroidism by medical means. And so what he's saying here is that in some point, and this was written in the 1940s, we will not be doing surgery and we will not be giving people radioactive iodine to treat Graves' disease. We're almost at that point, I think. Now let's just finish up talking about thyroid eye disease. There are many different terms for thyroid eye disease. The main term now is thyroid eye disease, or TED, but these are just some of the other terminologies that have been used to describe thyroid eye disease: Graves' eye disease, ophthalmopathy, orbitopathy, that sort of thing. But I think thyroid eye disease is what is now being used most. And just in terms of what's going on here, here are the immune system making the anti-TSH receptor antibodies. They're binding to the TSH receptor in the thyroid and causing hyperthyroidism. And in thyroid eye disease, these same antibodies bind to the tissues behind the eye, the muscle, the fat, and cause inflammation and swelling and scarring of the tissues and muscles behind the eye, causing the eyes to protrude and become inflamed and swollen. And this is just a cartoon showing a normal eye, and then eyes where the muscles are swollen and the fat is expanded, and the eye has nowhere to go except forward. So the eyes have this bulging appearance. There's a clinical activity score that is being used in many practices now to diagnose thyroid eye disease. And I won't read all these things, but if a person has at least 4 of these things, that predicts that they actually do have Graves' eye disease or thyroid eye disease. This last one, inflammation of the caruncle or plica. This is the caruncle, and this is the plica. And this is from a recent paper in a journal called Thyroid, where recommendations are made to practitioners about how urgent it is to refer a patient to an ophthalmologist. And so there's these are severe evidence of thyroid eye disease, corneal breakdown, thyroid when the patient has double vision. That's urgent. And then if there's swelling of the eyes and you don't know what's going on, or the doctor doesn't know, or if it's unilateral or asymmetric, maybe there's a tumor behind the eye that's not thyroid disease at all, or if there's quality of life issues, the patient should be referred to an ophthalmologist within a few weeks. And then finally, if the person is doing okay with their thyroid eye disease, it's not urgent, but probably a person should be referred to an eye specialist. And also patients should be told about doing things to prevent the development or worsening of the eye disease, especially smoking. For reasons that are not clear, smokers have a much higher risk of developing thyroid eye disease than non-smokers. In terms of how thyroid eye disease is managed or treated, I don't have time again to go into this, but all people should, first of all, have their thyroid disease managed with methimazole appropriately. They should be told to quit smoking, and they should be seen frequently by their primary care doctor or their endocrinologist to assess the disease severity and activity, that is the eye disease. If the eye disease is mild, then there's really nothing that needs to be done. Some studies have shown that selenium supplementation may improve thyroid eye disease. If it's more severe and there's a lot of inflammation, intravenous steroids, glucocorticoids may be something to consider. And if it's stable, then there's really nothing more to do. And often over weeks and months of time, the eye disease actually gets better and resolves over the course of months to years. But if it progresses, then this is called active thyroid eye disease. And there are treatments, including glucocorticoids or steroids intravenously, or this new drug called teprotumumab or Tepezza that maybe some of you have heard. People can respond to this, and if they do, maybe add a drug called mycophenolate or give another course of teprotumumab if they relapse, and then hopefully it will be stable and become inactive. But some patients need surgery to correct double vision, even though their inflammation has decreased markedly. And if it's sight-threatening, then intravenous steroids. And if they don't respond, then they need urgent surgery to decompress or remove the soft tissue from the back of the eye to restore the eye back to its normal position. I'm not going to talk too much about Tepezza or teprotumumab, except to say that this drug acts by blocking the IGF-1 receptor in the back of the eye. By doing that, it decreases the inflammation and swelling in the back of the eye. This is not that easy to take. The person has to come to an infusion center and receive an infusion every 3 weeks for 8 infusions. There are side effects, as I've listed here. It's very, very expensive, $200,000 in US dollars for a course of 8 infusions, and it is not available in the world except in the US and recently in Brazil. And also, there are no trials where it's been compared to the typical treatment, which is intravenous steroids. This is just from one of the studies of teprotumumab versus placebo, looking at the degree or decrease in the protrusion of the eye. And these are the responders. And you can see over the course of the 8 infusions, about 85% of people had a good response compared to only 10% in the placebo group. There are other treatments for thyroid eye disease as well coming down the pike. There are drugs like teprotumumab, which might be able to be given orally or subcutaneously instead of these infusions, which will make things, a lot easier for patients. There are blockers of the TSH receptor, which might be able to block the action in the back of the eye. There's another drug that blocks some of the part of the immune system called interleukin-6 receptors. And then there's another drug that acts as an anti-B cell agent, and B cells are the cells in the body that make antibodies. So just like with Graves' disease and new treatments targeting the immune system, there are a lot of new treatments that are coming along that also target the immune system, specifically in the realm of thyroid eye disease. So this is what I spoke about. I went over a little bit about anatomy and physiology of the thyroid. We talked about the treatments for Graves' disease, and then spent a little bit of time talking about thyroid eye disease. And this is where I work at Johns Hopkins Hospital in Baltimore, Maryland, and I thank you very much for your attention.
Thank you, Professor. I hope that you all enjoyed in this wonderful presentation. I welcome you to the next webinars in organization of Thyroid Federation International. Please follow us on social media. Thank you and see you on the next webinar. Bye.